First thing to do is get the panel to introduce themselves. So start at this end with Jane.
So I'm Jane Marr, I'm an oncologist and I'm the Joint Chief Medical Officer at Macmillan.
And I'm Diana Greenfield and I'm a consultant nurse in survivorship and late effects here in Sheffield teaching hospitals.
Hi, I'm Sean Duffy, I'm the National Clinical Director for Cancer for NHS England.
Hi, I'm Kevin Stein, I direct the Behavioural Research Centre at the American Cancer Society.
Hi, I'm Juliette Bouverie, Director of Services and Influencing at Macmillan.
I'm Richard Metcalf, I'm Head of Strategy and Delivery for Doncaster CCG.
And I'm Helena Davies and I'm here as a patient representative, users representative, whatever the current terminology is.
Brilliant, thank you very much, ladies and gents. The first question that has been posed to the panel is, what are the 3 commitments you would like to see to significantly improve cancer services for patients? And I think, Kevin, were you going to take that first?
Yeah, I think I've been volunteered to be the guinea pig. I'm probably the least qualified person in this room to tell you how to change.
You've come all this way, though.
But I know I've really tried to pay attention today and learn about your healthcare system, and I, again, just wanted to reiterate how impressive it is and how well integrated it is. But I think there are some universal things that still hold true, and I'm interested to hear your thoughts on these. But in terms of commitments. And I actually heard a lot of this already happening, especially when Fraser was talking about including patients as stakeholders. So my first of 3 recommendations was to really include patients as full stakeholders in identifying the sort of patient-centered issues, the problems that they identify as important, and include the patient in the development and the design and the evaluation of programs and interventions, and really get them to be full stakeholders at the table. And as I mentioned earlier, PCORI, which is a patient-centered outcomes research institute in the U.S., has mandated that all grants, research studies, actually include patient stakeholders on the panels to make sure that the patient viewpoint is represented. So that was one point. And the second point was to sort of recognize differences in patient populations, and I know that that's a challenge when you're trying to deliver services to large numbers of people, but really there's not perhaps a one-size-fits-all. So recognizing cultural differences, ethnic backgrounds, different preferences of different age groups, sexual orientation, gender, those sorts of things, taking those, and we know the population is changing. It's becoming less homogenized and more diverse. All over the world, and I know that in the United States that's happening. So recognizing that different groups have different needs, and taking those into account as we develop programs and policies. The third is pretty obvious, in that a commitment of funding to develop and implement and test and revise, and importantly maintain and sustain programs. So, there's got to be that commitment, and I don't quite fully understand the whole commission policy structure that you have, but clearly to improve cancer care, the funding is, maybe you guys don't either. And I was just talking to someone who's a GP, David, I think his name was, and we were talking about, how do you change behavior? And there's individual, and I saw a lot today about one-to-one behavior change, and I'm all for that because I'm a clinical psychologist myself, and I think we need to provide services one-on-one. But I think we should also keep in mind that the biggest drivers of behavior change are usually policy. So I take as an example tobacco. So we can do smoking cessation, and we should do smoking cessation for people who want to change their behavior and stop smoking. But the biggest impact on smoking is raising excise taxes on cigarettes and making smoke-free environments. So I think if we want to really change behavior on a society level, and I'm including obesity, physical activity, diet, and smoking in that, I think policy is an important component.
Thanks very much, Kevin. And actually, the impartial observer from the outside is really valuable to challenge some of the views that already exist. So, anybody else open to the panel? Anybody like to? Additional comment?
I think one of the good commitments would be if patient experience, measured however you want to measure it, had the same value and ability to drive and incentivize change as much as any other hard clinical outcome. We've got a good basis and understanding of what makes for a good patient experience based on 4 years' worth of a national survey. And I think the next step should be to translate that into hard-edged, with that good quality delivery comes good quality money.
In terms of experience, building on the patient experience survey, it's clear, and this is from a nursing perspective, that that patients with and living with and beyond cancer appreciate the role and the input of the clinical nurse specialist into the role. We have more clinical nurse specialists than ever, but it's still not enough for each cancer patient to have their own dedicated clinical nurse specialist who who is prepared not only to care for the patients during active treatment, but beyond that. So there is underpinned with workforce skills, and that includes transition points that we've been talking about into primary care. So we have a real flow into primary care, and primary care nurses also have the same skills, and maybe seeing that through. So there is a real dedication to making sure that the workforce are equipped to deliver the care.
Excellent. Okay. Helena.
I mean, I think Kevin talked very rightly about the importance of having patients involved in planning programmes, but I think it's also absolutely critical that we achieve a state where we really have patients at the core of their own management, and that we really are promoting self-management where patients want it, because actually not all patients actually want to manage themselves, but that they're empowered to do so, and that they're empowered to do so within the context of their own environment, their own experience, whether or not they are familiar with healthcare, whether or not they're familiar with taking control of their health. And I think that's particularly pertinent in the context of the comorbidity kind of scenario, where some of them will already be very familiar with self-management. Perhaps if they've come through, say, they've got diabetes and they have come through an innovative diabetes team, why would you suddenly place them in a situation where they've got another diagnosis and they don't have the same level of control over their health? And it improves patient outcomes. We know it improves patient outcomes, and I think in relation to what Sean says, it improves patient experiences as well.
Thank you. Any further comments on that? We move to the second question. The second question we have is, what do you think are the biggest barriers to improving cancer services, and how can they be overcome? Jane, would you like to take that?
Okay, so I'm going to just throw in 3. So I think the first thing is that there isn't really a shared understanding of cancer, of how cancer has changed, the different sorts of cancer. And so there's a need for everyone who can help people with cancer to understand how cancer has changed. So there's a shared understanding. I think that's the first barrier. I think the second barrier is just recognizing that in order to make change, you have to play a long game, and that it takes 10 years. The median survival, I think, of a chief executive in a hospital is 3 years, which means that every 3 years you're going to have to keep retelling the story and changing the story and bringing a whole lot of other people on board. So I think the recognition that it takes a long game, and that you have to keep retelling the story every 2 or 3 years, you can't assume that everyone's got it. And I think finally it's actually getting from the cancer specialist workforce, engaging the cancer specialist workforce to understand that they have a responsibility for more than just treating the cancer. So both nurses and doctors and everyone involved have to share their skills with people that they didn't recognise were important in the role of patients.
Anybody else on the panel? Sure.
I suppose one of the things that you could also add to that is that we're in the world of cancer and cancer patients' experience and their care, we sometimes feel we're in our own little world, and that there is now a much bigger world out there where there's great opportunities. So one of the barriers could be it's all about us and cancer, whereas in fact there's a lot of common ground with every patient that struggles with a long-term condition, with every patient that struggles with a late diagnosis, which isn't necessarily unique to cancer. The flip side of that, of course, is that we're committed, passionate, locally, regionally, nationally, and politically. And that's really good. And it's how we capture and hone that strength and not let it be a barrier.
Thank you. Julia.
I agree with Jane about her first point about changing perceptions about cancer, because there's no way people are going to commission or deliver the recovery package if they haven't got the basic message that actually people need support to recover. I think sometimes the complexity of the recovery package puts people off because it's the 4 component parts and people kind of don't know where to start. I think the most important people is that just get going with one element of it and just try and keep it as simple as possible. I'd say one of the other barriers is people working in their own silos, and a lot of hospital-based staff just not having relationships with people out in the community and not actually knowing what some of those community-based services are. And as we've discovered in Doncaster, actually, there's a lot of appropriate and relevant services, but they're often delivered by quite small organisations, and a lot of hospital-based staff are just not aware of what's out there. So I think people thinking beyond their own institutional boundaries and working much more across the whole system is really important. And then I think one of the other barriers is actually we haven't got to a point yet where we've made patients sufficiently aware of what actually they're entitled to and what they should be asking for. So, patients don't routinely say, where's my care plan? Who's my key worker? And I think actually if we could equip patients earlier on in their journey to start asking for some of these improvements and changes, it would be another.
And does address exactly those points. If we can implement those more routinely, then that would help significantly. Yeah. And I think the other thing just to say about the silo working is really, really important. I think that's the biggest barrier, not just across specialist cancer and primary care, but within specialist services, surgery, talking to oncology or radiotherapy, and then equally health, talking to social care. So it's because of the funding streams that cause these barriers, and I think those are artificial, and we should be sort of trying to subvert those as much as we can for the benefits of the patients.
At the end of the GP conference, the mantra was, go hug a surgeon.
There's plenty around, so if you get the urge later on, then that's all about Helena.
I suppose 2 points really. One was in relation to Juliet's point about empowering patients early in the journey about what they're entitled to. I think somehow, and I don't know how we do this, and it's very aspirational, that really we actually need to empower patients before they ever start the journey. Because as soon as you become a patient, and I worked in medicine my whole professional life, so I was used to hospitals, not frightened of doctors, none of that stuff to deal with. You are so vulnerable that you become often incapable of even doing the most simple things. And I don't know how we do that, but I think it's a really fundamental cultural change that we need to achieve. I suppose the second point is just to reinforce Diana's point about communication between healthcare professionals, not just between secondary and primary care, but say within secondary care. I have often felt in the course of my complex chronic healthcare needs, I think, that the only person who really knew what was going on was me. And that if I didn't keep control of the situation, I might die. And that's quite a scary position to find yourself in.
Thank you. Kevin.
Can I just add one point? Because I think I've heard a couple of times say, sort of fatalistic beliefs, in the general population. I think we need to communicate that cancer is treatable, that you can survive cancer, and that if you catch cancer early, your outcome is going to be much better. Because I heard several people mention today, that people say, oh, yeah, I've got cancer, it's going to, what will happen, it's in God's hands, or, that kind of fatalistic belief that there's nothing you can do leads to people presenting with later stage disease when it's not as treatable and the outcome is poor. So we really need to communicate to the general public, cancer is treatable, we can catch it early, and you can survive this, and you can have a good outcome. And as Richard told in his story, he caught it early, and he had a very low invasive experience. He had surgery, he was done, he's pretty much symptom-free. So I think that message really needs to get out there if it's not yet.
Excellent, thank you. Any further comments from the panel? Okay, we'll move on to the next question. And actually, Jane, in your earlier answer, you mentioned the long game, 10 years. The next question is, what will care of cancer patients look like in 10 years' time? What will care of cancer patients look like in 10 years' time? Anybody from the panel to start on that one?
Better.
There you go. Sold. Thank you.
More holistic. I would really love it to be more holistic. I mean, we heard earlier, I think it was Lindsay who talked about that it was early days for the holistic component, which is physical exercise. Now, physical exercise is really only just holistic. I mean, physical exercise is pretty mainstream accepted as being of benefit to your health. And as you'll hear later, I found some slightly more left field things have been extremely beneficial to my health, and there is actually quite good evidence to support them. And they're not included within the healthcare service at all, and they're provided by charities like the Cavendish, or, you know, we heard about one in Derby as well. I'm sorry, I can't remember the name. But, you know, I hopefully more holistic.
Thank you, Richard.
Yeah, I just wanted to say I think that we see what care will be like in 10 years now with examples like Richard's example. I think it's about best practice becoming routine practice across the pathway. So the public and patients being aware, presenting early, and the intervention happening at the right time for those patients.
But to be a bit of a naysayer, perhaps 10 years is really a short amount of time to expect massive change, and to not to be pessimistic, but last night we were at dinner, and I think it was Derek Rosario told a story that they asked the chairman of China, and this was like in the 2010 or something, what do you think the impact of the French Revolution was? And he pondered for a minute and he goes, it's too early to tell. So, you know, I mean, and if you look at survivorship care plans, they were recommended back in 2006. And we still don't have them used in a widespread way in the U.S., and maybe they're a little bit more widespread here. But the idea that, you know, it takes 15 years for a major research finding to move from the research study into actual clinical practice. So let's not be too hard on ourselves in 10 years from now if we're not, haven't achieved great things, because it's going to take time for things to really change.
Okay, I'm going to challenge that. I mean, I would. I just think, you know, we're onto something so good, and I think we should be ambitious. And, you know, in 10 years' time, I think we should be aiming for those bits of the recovery package to be universally available for everybody. I mean, I don't think that's an unrealistic aspiration. We know it's a complex system. We know doing this stuff takes time because it requires a lot of cultural change. But I think if we don't set ourselves some measurable targets, then of course it's going to take forever. Yeah. But, you know, those things in the recovery package, we know they're doable. They require a lot of system and cultural change, but wouldn't it be great if everybody who's newly diagnosed just routinely gets their needs identified, assessed, they're supported with appropriate care planning, health and well-being? I mean, I don't think that's an unrealistic expectation, so that's what I'd like to see.
Diana, thank you.
I'd also like to advocate for my allied health professional colleagues who aren't up here. And we've actually not heard so much from them today because we've heard the pull in and the pull out. But I think sitting around the table and providing equal care for being able to help patients are the physiotherapists, the occupational therapists, and not just inpatient cares getting patients out of beds, but actually long-term recovery. And so, and the other therapists as well, and not forgetting, importantly, psychological. We absolutely need to have those far more and for making decisions in the multidisciplinary team alongside the patient care, and they need to be included in decision making.
And you'll have to commission your treatment demonstrating that you've actually measured the quality of life afterwards. So you won't be able to commission a new radiotherapy machine unless you can demonstrate that what the problems are of your population of your last radiotherapy machine. So we link patient-reported outcome and commissioning of technical equipment.
And finally, thinking about radiotherapy, I look after patients with late effects. Okay, so I'd like to be retiring in 10 years' time with very little to do.
Now there's an ambition. Any further comments on that from the panel? We have time, I believe, for we can squeeze one, maybe two questions in from the floor. Is there anybody out there who wants to challenge our esteemed guests while we have them in front of us? We have one at the back there. I don't know, Rachel, there's two back there. We'll go for the gentleman with the white shirt first.
So, yeah, just actually following on from the last question, do you think that information technology such as predictive analytics may have a role in empowering patients and improving the patient journey in the future? Things like IBM Watson and stuff like that, and apps and measuring device and things.
That would depend a lot on, speaking as a patient. I like technology, so I think for someone like me, it would improve the patient journey. Uncharacteristically in our household, I'm the woman who's more technological than the man, although I'm told that's complete reverse of usual. People always say that in a very sexist way. But I think we do have to remember that there still is a significant proportion of the population who don't have access to computers, who are not computer savvy, and also that the growing part of the population is an elderly population who are the least computer savvy of all. So I think we need to start implementing, because obviously use of technology will catch up eventually age-wise, but I think cautiously, even though I personally am an enthusiast.
I think the data crunching ability of IT to be able to feed real-time information both to commissioners and to managers will be really, really important and will make a significant difference if it can be harnessed properly.
I think we can build on the community aspect of e-health and mobile health, e-health, electronic health, because I think we can, a lot of times we'll recommend interventions to people, but with the mobile technology where you can create a community where people are comparing their behaviors to other people, like there's a thing called Map My Walk, if you wear a Fitbit, you can see what other people are doing. There's some peer pressure there. So I think that's one component of technology that could really change the landscape a little bit.
Thank you. We have time for one more question. I believe it's a lady at the back.
Hello, my name is Karen Holmes. I'm Centre Manager at the Cancer Information Centre in Sheffield, but I'm also facilitator for the Network Patient Partnership Group. We've heard from the panel, we've heard most of the day, patients are very important, and actually changing services, we need patients in that, helping us to shape the future. How are we going to do that if we don't have the funding to help them facilitate? Patients don't come for free, they need supporting, they need facilitating, and the Network Patient Partners Group is struggling. We've no funding. We've actually applied for some short funding from Macmillan. But what's the future of groups? How should we be funding them? Perhaps for Mr. Duffy.
Save me having to point somebody out.
Ex-ward nurse from Northern General. Thanks, Karen. The first thing to say is the patient voice is absolutely important. Patient experience is very important, and to link it. It should be the business of anybody that commissions and provides services that they have a structure to allow that to happen. This is not a diktat nationally that should thou shalt. It should be common sense, and it should be where's your starting point in any change that you want to introduce as a result of provision or commissioning? You go to public consultation. That's just standard. So it's de rigueur. It is business as usual, and it should be supported in that way locally, in my view.
Yeah, thank you very much. We clearly have heard that message. I think the examples that we've talked about in Tom, Richard, Ali, and myself will talk about soon in Doncaster is exactly what we've been doing.
Any other final comments from the panel on either that question or any others that came up? We have about 30 seconds left to finish up.
I think I'd just make a reflection that one of the things that I hope we'll better address in the updated cancer strategy is what some of the levers and incentives need to be in the system to get some of this good practice that we've been talking about today actually routinely happening, because commissioners, there's no sort of compulsion on commissioners to set aside part of their budgets for things like user involvement and user engagement. And there's fantastic stuff happening around living with and beyond cancer, almost despite some of the kind of commissioning incentives. So we've had quite a number of discussions at the Cancer Strategy Task Force about how we can kind of create some more levers and incentives and more accountability locally to kind of drive some of the good practice.
Thank you very much, Julia, and thank you very much to the panel. That does neatly take us to the end of this session, so thank you very much to the panel. Just in time,